first of all, my name is Fiona Lyne. I'm the Director of Communications at the Foundation. Can I remind you to download the app, because we are going to be submitting all our questions through that over the course of the conference. And first up today, actually, we have Russell Roberts. And Russell was getting on his flight in Australia and unfortunately was not able to travel just last minute. So he's very disappointed not to be with us in person. So we've slotted him in here. So Russell is the Director of Equally Well Australia, and he's going to be talking to us about using a collective impact approach to enable system-wide leadership. So Russell. You're next.
Thanks, Fiona. And I'll just share my screen. If you could just confirm that you can see the screen okay.
Yeah, talking to the mic, yeah, you can hear you.
Okay, great. So, yes, my apologies, everyone. I was due to be coming there a few days ago and not permitted to get on the plane, so I'm very disappointed not to be here, but thank you for the flexibility. Fiona, can I just check the timing as well? How much do I have?
15 minutes, Russell.
Okay, great, thanks. So just a little bit of a very quick background, and then I'll get into the leadership model.
Russell, if you just, Russell, just before you start, if you just put your slides on presenter mode, we're just, yeah, perfect. Got them.
Yep.
Thank you.
Got it? Great,
yeah.
Good. So Equally Well is a movement which is addressing the physical health of people living with mental illness. I won't go through to detail because you can read quicker than I can, but really the physical health outcomes for people with mental illness are far worse, as is their life expectancy. And this is a major problem. These are some of the data. And just when we look at this, about 12% of the population, for example, they represent the majority of preventable deaths from physical illness. So in actual fact, 10 times more people die of preventable physical illness than of suicide. If we think about cancer as an example, each day in Australia, based on the Australian Bureau of Stats, 16 people die prematurely of cancer. This is the basic population rate. It should be 1.8 people per day. This is a major issue about discrimination. This is despite the fact that the incidence of cancer is about the same or lower than the general population. So it's a problem. What's more important, I think, for this conference, when you think about the integration of physical and mental health, is this is the percentage of people with psychological distress who are in good health. If we put poor health, and this is a percentage in Australia, Aboriginal and Torres Strait Islander people, it's a much higher percent of people suffering psychological distress in good health. Now, if we add chronic disease or reported poor physical health, this quadruples. And so not only does it quadruple for non-Aboriginal people, it does for Aboriginal people as well. And so that gap gets better. I hope this is a powerful demonstration of the impact of physical illness on psychological distress and mental illness, and the real importance of addressing both at the same time, including, of course, some of the antecedents of poor physical health and chronic disease, as we all know. Just quickly around COVID, people living with mental illness have about 1.5 to 2.5 times the rate of COVID-related infection, serious illness and death. In Australia, 5 times more likely to be hospitalised for vaccine-preventable conditions, 6 times the rate of vaccine-preventable days in hospital, and 7 times the rate of flu vaccination days. Just a little bit about Equally Well. Equally Well is a movement and a policy to try and address this gap in physical health outcomes. Just a little bit about it briefly. It's equality-based. It's about equally well, and it's premised on the fact that people with mental illness have an equal right to quality of healthcare and quality of health outcomes, which at the moment, demonstrably, they do not, right across the world. We're looking to address some of the system challenges, such as stigma, diagnostic overshadowing, and this is where people with mental health go to a doctor or a mental health professional. The mental health professional focuses on the psychological disease or the mental illness, but really, and including suicide risk, but overlooks things like cardiovascular risk or cancer risk or diabetes and other screening, which is that's the overshadowed. So they're focusing on the mental illness, but they forget that really the importance of physical health in terms of the person. A little bit more about this. The evidence for this is overwhelming. There's over 135 systematic reviews and meta-analyses around the physical health of people with serious mental illness. And that's a graph of the research articles over those last number of years through to 2013, and it's continuing up. So it's the evidence for this is bulletproof. Impact driven, the cost of the chronic disease and the comorbidity and the coexisting, this is just the cost of this, not mental health generally, is 15 billion per annum in Australia, 1% of the gross domestic product. The other thing we're doing with Equally Well is actually trying to align with this with policy and influence the development of policy. And this is the policy history that we've been trying to be part of that narrative because of the evidence over the last 20 years. And this is really important in terms of the authorising environment and trying to lead a movement and the provenance and the governance. You really need to get this located and advocate within the policy environment. And this is Equally Well, 6 essential elements. You can read that quicker than I can, but a really important part, number 5, is better care coordination is one of the key essential elements of Equally Well. And that's what we're focusing on here. These are some of the national policy frameworks that we've influenced and been able to really inform and in fact get priority in that. And likewise in Australia, we have national policy environment, but we also have 8 states and territories. And so they're the state context or the state and territory context for Equally Well. And once again, we've managed to get this into their policy authorising environment. The really important thing about Equally Well is it's more than the research and it's more than the policy, it's action focused. So Equally Well has 14 actions, which is brought up by that consensus. And once again, the quality of everyone's expertise, that these are the actions that we've agreed to do. Now, in Australia, you probably may or may not have seen this before, and it's probably similar to a lot of other nations. We have a very fragmented service. And so trying to address an issue in a system that's not command and control, but so many different players funded from so many different funding streams is incredibly, incredibly difficult. What we have done is have a collective impact approach. So on its launch, we really wrote, and in its development, the development was a number of these partners, but now we have about 100 partners who have committed to make this issue a priority within their remit. That includes every state and territory government and the Commonwealth government, a number of NGOs and consumer peaks, chronic care peaks, and the professional colleges as well. And it's critical to the collective impact because our motto is that, I'll just go back, I'll get to our motto in a sec. Those of you who are not familiar with collective impact, just very quickly, it's got 5 major elements of, getting people to agree on a common agenda, shared measurement, mutually reinforcing activity, continuous communication, and backbone support. So in terms of the governance and leadership, the role of Equally Well, our backbone team, which is a backbone support, is to manage to keep all of these things front and focus for all of our partners. Like you and a lot of areas, in a way, different parts of health, and this is where it's really, I think, pertinent to integrated care, is various sectors, they live in their own little galaxy, and that might be, general practitioners or the public health or the non-government or community managed organisations, the professional colleges, and they're mostly in their own orbit and they're most comfortable in their orbit. Really what we try to do is connect people with a shared agenda and a communication and link. And we call it a constellation model of collective impact, which has come from the Tamarack Institute in Canada. Because really what we want to do is connect the different parts of this, because people go across all of these constellations. And so we're really trying to connect this universe of healthcare in order to have more integrated care. And I think this is really important. That one of our mottos is you do what you can, where you can, when you can. So we continue to engage, to raise the issue and keep the communication going, but understanding that different organisations have a different priority at certain times, different capabilities, and quite frankly, different capacity. to take on new projects or to prosecute in one particular area. And so because we are run independent of government, we're run out of a university in Australia, and regional Australia, in fact, we have no power other than power to support and encourage and connect and coordinate and collaborate. And an example of this is one of the states and territories has been a partner and committed to this probably for 3 or 4 years, very little action, almost 5 years, in fact, very little action. But now they're taking it on with great gusto and making it a priority and doing a whole planning service in terms of developing their equally well implementation strategy, and an integrated one across primary health care and public health care as well, and going through that process of joining up with community managed organisations. And we're very pleased to support them with this and also connect them to other states and territories that are further along in that journey. That's a collective impact where we minimise the duplication and replication, but we really think that everyone who moves is the next generation to sort of build on the learnings of those in front of them. We did a scan. We've been going almost 5 years, and we did a scan in 2019 with our partners, and we found there was 380 actions underway against the essential elements of Equally Well, and another 152 planned. We're just in the process of doing our scan now. It's been delayed, like a lot of things, because of COVID. So what do we do? I think I've got about another 3 or 4 minutes here. So what do we do? It's a 3x3 focus. So our job is to keep the issue live and vibrant across all the sectors. And it's also to facilitate collaboration around the issue, around initiatives, to access the resources, and finally to sort of measure collective progress across, once again, across all of those sectors. We do this in a number of ways, and one of the ways is by having a series of ambassadors across the various different aspects of healthcare to, in a way, represent Equally Well and keep it on the agenda, but also to feed back to us any events, any planning, any policy developments, so we can be connected and support that, clearly with a focus of improving the physical health of people with mental illness. This is the other reason, and I talked about the integration before, about physical health, but another reason is that when we look at the proportion of suicides, you notice that almost 50% of these suicides are related to a physical health issue, a chronic physical health condition. So while we've tended to separate mental health and physical condition, this is another aspect, and I think vastly, largely unrecognised, of by improving the physical health and well-being and community connection. In fact, it's one of those areas that we could really reduce the rate of suicide, and it's been overlooked, the importance of, but when we think about it, if someone's got chronic physical disease and disability, that's so depressing, and it puts a wet blanket over hope and a bright future. So improving the physical health, we believe, is probably one really great way to lessen the chances of suicidality, in addition to, of course, just improving person's quality of life, which is so important. In terms of the national, and so some of the things we're doing, a lot of this is about stigma and discrimination as well. So we're, in fact, in the workforce looking to just develop some programs to improve the and develop a lived experience workforce, in addition to training for clinicians. So these are some of the things we do. We've recently had our annual Equally Well Symposia, where we try and identify the best practice around Australia and bring that together. And we had that around Easter this year in the Gold Coast in Australia, and then promote that booklet. If you go to equallywell.org.au, we have our last conference proceedings there, and in about a month or two's time, we'll have this conference or symposium proceedings there. And this is about, once again, connecting people, but sharing and encouraging collaboration. I mentioned our ambassador program. We also have a webinar program and a series of communities of practice. So people from government or from CMOs or particular focus get together regularly, and we facilitate that to just keep talking about what we're doing and opportunities to collaborate. From that, we've managed to have a collaboration between 15 local health districts, community managed organisations, and universities, all in the one project to improve the physical health of older people living with a mental illness. And we're really excited about that collaboration that we've been able to be part of. We're having success. I mentioned all those 380 actions to improve that. There's examples of case studies of people who, for example, breast cancer is the highest elevated risk for early death for people with mental illness. It's not the most common, but it's highest elevated risk. And one of these projects, we're having reports back of the screenings, and they're finding that, detecting it and treating it, saving people's lives. And that's just one life. And you think of the impact that has on another 20, 30 years of healthy living, on them, on their work, on their families. And it's just profound. Also, we've been curating the global call for vaccine equity, which you'll find on our website, and our advocacy, continuing advocacy. We also have developed an international collaborative learning network, and if anyone's interested in this area, you're welcome to join us. And I've got the details here, which we established in Washington in 2019. Had a few hiccups because of COVID, and I'm still struggling through that. So listen, everyone is equally well. Anyone who's concerned about integrated care and wants to improve the physical health of people who live with mental illness, we say is part of Equally Well. We're with strong partners with friends in New Zealand and the UK, and in our international collaborative network, we have another 12 countries that are regularly involved. So really, the hub of this is getting the provenance right, about getting consumers here as equal with researchers and policy people and implement and clinicians, having the data, and then connecting people regularly. And that's really our job, to maintain our integrity. And I think we've managed to do that, and it's keeping it on the policy agenda, because it's such a change of practice. And so I think that's my time. The last thing I want to do, Fiona, is get you late as a first presentation. Thank you for being so flexible and coping with my sudden change of circumstances. And I wish all of you online and in person the best. Thank you.
So thank you very much, Dr. Robert. We are really happy to have you online. And we are now giving the floor to the researcher Thieme Stap, who has a great interest in health innovation and the learnings of those involved in the innovation. So,
thank you. Can I put this here? Yeah. Yeah. Good morning, everyone. So nice to meet you. I'm really happy to be here. It's the first conference I've been to since COVID, and actually the first conference during my whole PhD, which ends in September. So it's good to be here. I'm going to take you along on my favorite research project, actually. But it's also good to know that if you have any questions and put them in the app, I will respond to them later. So know that that's a possibility. Okay. Now to the research. I first want to start with you closing your eyes, if you feel comfortable doing that. Just a second or two, it's not long. Imagine yourself to be in a photographer's studio. What do you hear there? Maybe you hear hold still, and then the clicking of the camera. And then you open up your eyes again. Our research is about taking time. It's about listening. It's about holding still together. It is also about movement, about touch, about trust. We tried out something new. We explored what photography could bring to our participatory action research methodology. We felt we were onto something. Maybe one step closer to an answer to a question that we have been pondering for a while. How would scientists have to research person-centered care if their very endeavors were to contribute to it? What you see here is during a session in the photographer's studio. Leonore and Dominique came over to talk about their personal lives, their care situation, and about their relationship. Dominique has Parkinson's disease, and Leonore is her nurse. Today we will talk about 45 to 60 minutes, and that's an eternity compared to what the time they normally have. Richard, our photographer, takes the photographs, and the two of them are also portrayed individually. We would audio tape the conversation, and every now and then ask a few questions, but not intervening too much. Historically, medicine, like modern science, have moved steadily towards a more reductionistic view of the human condition. Together with a neoliberal style of running hospitals, these trends have given rise to a sense of alienation. At the same time, care is fundamentally about the so-called human touch, and the intuitive side of the profession that seems to tap into things that matter and neither can nor need to be measured. Nowadays, the arts are more and more accepted in healthcare settings, and not just as a means to an end to liven up the place, but it's really considered a powerful set of disciplines that excel in many human faculties that medicine is yearning after. Think of creativity, critical and divergent thinking, sense-making, and perspective-taking. It is quite hard to create perspective transformations. That is the reason why we search for methodologies and ways to get that going. Helping hands, we called them. We thought it would help if everybody brought a personal object. You can see some of the personal objects people brought here. It would function as a Kickstarter to the conversation. In the literature, this is called a boundary object. This boundary object, the taking time to listen and going to people's homes, I will come back to that, makes it that there is a deeper conversation and perspective transformation is more easily reached. One of the goals of the research is to bring about that perspective transformation. This means to learn to see through the eyes of the other. Is that my mouse? That's annoying. Sorry. It means to learn to see through the eyes of the other and sharpening up your frame of reference. Here you can see two people performing a neurological test to determine the extent and the progression of the illness. Bas Bloem, he's quite a famous neurologist, Parkinson's neurologist, says about this moment, "You see the movement of his index finger. That is quite cool. It is also interesting to see how he opens up his mouth a bit, as you can observe often with people who have Parkinson's. His hypokinesia manifests itself because he's working so hard." Bob had a completely different experience. He is a Parkinson's patient, and he says, "In this photo I see the teacher and the little boy. I don't know whether that's a problem because it's just an exercise, but it might also happen that you come into a mode of being that you can not so easily escape from." After each studio session, we visit both participants at their homes. Here we are sitting at Bob's table looking at the photographs. Notice that the photographs have also become a sort of boundary object here. Bob says, "It was good to see Bas, the human being, instead of Bas, the doctor. I normally have to be so quick. I have only 10 minutes. Sometimes we have half an hour, but then we're doing all these tests. Now we could really take our time and get to know each other." On our way back to the hospital, we discussed how far person-centered care should venture out into the world. Maybe all the way home? This novel research method yields very rich and thick data. So we decided to use the data in educational settings. Both university students from every study, so with every background, and vocational training programs such as the training of nurse specialists. We tried to put participants in a beginner's frame of mind by, for instance, letting them see the photographs or the quotes without any frame, and then let them create their own narratives. The next step of our research is to incorporate this in the education and the long-term development of professionals working in Parkinson's care. There is a book chapter coming out on the methodology. It was supposed to have come out in January, but there were some problems with Springer. I have it, so if you want it, let me know. I can send it to you already. And there's a photo book, as you can see here, coming out in December 2022. If you want any information about that, please let me know. If you want any information about the rest of my research, also let me know. And for now, I wish you pleasure with the conference. It's a joy to be here already. And I have one last video to show you. And I think I even have some time for questions, maybe?
I think we are many presenters today,
Okay,
so let's
okay.
see by the end of the presentation.
Let me see if it works then.
There are 10 million Parkinsons in the world, and it grows so fast we cannot deny. We need a lot of different ways to turn the tide. We need 10 million treatments of this disease. No one's the same, so the remedy needs change. They all deserve a tailored treatment to their needs.
So thank you very much. I would like now to give the floor to Jonathon Reid, who is our colleague from the Health and Social Care Alliance from Scotland. It's online. I don't know.
Hello, yes.
Yeah.
Hi, good morning. Thank you, everyone. I think it's pre-recorded, so I think somebody needs to press a button.
It's me or it's... Okay. So that's all, no?
Hello, and a very good afternoon, or indeed good morning or good evening, depending on where you're joining us from in the world today. And welcome to this presentation, which is entitled The Scottish Sensory Hub, a platform for people living with sensory loss in Scotland. So my name is Jonathon Reid, and I'm based in the city of Glasgow, which is just to the west coast of Scotland. And I work with an organisation called the Health and Social Care Alliance. I am the national coordinator for the Scottish Government's strategy, the See Here strategy, and we'll talk a wee bit more about that later on. And I'm also the manager of the newly formed Scottish Sensory Hub based at the Alliance. And today we're going to learn a wee bit more about the strategy and the hub, and we'll sort of talk a bit about how they interact together and connect together. I also coordinate a group called the Nordic Cognition Network in relation to congenital deaf-blindness, and we'll maybe also look into the scope and range that that organisation and group has for some international links and development and research potentials within the context of this conference too. To begin with, however, I thought I would just have a look at how we would describe the term sensory loss in Scotland. And who the Scottish Sensory Hub actually works with. The term, as we can see, can refer to anyone living with either a congenital or acquired impairment to their vision, to their hearing, or to both their vision and hearing. And this can be a lifelong condition, or it can impact the individual later in life. And currently the population of Scotland is around 5.5 million people, and 1 in 5 people, just over 1 million, are living with a type of sensory loss at the moment. We would consider 3 broad types of sensory loss in Scotland. We have deaf or deafened or hard of hearing people, and this may mean an individual who has been born deaf and maybe has developed communication through a language such as British Sign Language. It may mean somebody who has become deafened within later life and has lost the ability to receive a spoken language or use a spoken language such as English. And it may refer to somebody who has become hard of hearing in later life. And this might mean that they rely on technical solutions such as hearing aids to communicate, or maybe use things like lip reading. In terms of sight loss, again, the condition of sight loss can be incredibly varied, and it can be incredibly individualized to the person. The age of onset of this condition will be critical, as will early intervention, and to develop learnt skills such as Braille, for example, or long cane guiding and navigation, and many other skills as well. An individual may have very low visual acuity or have very high levels of peripheral vision but little central vision. For some individuals, factors such as night blindness or other environmental issues may come into play. And then lastly, we would consider deaf blindness, and we would consider deaf blindness to be a combination of sight and hearing loss that impacts a person's ability to communicate, to access information, and to travel around their environment. And in the UK, it's sometimes also called dual sensory loss or multi-sensory impairment. And in Scotland, we would consider 2 main categorisations of deaf blindness, and that would be congenital and then acquired deaf blindness. And congenital deaf blindness would mean that the condition is present from birth or from before language occurs in the human infant. So this would be around the age of 2. And this may be through a condition in pregnancy, such as maternal rubella syndrome, etc. Acquired deaf blindness would be much more common and would mean that the age of onset of the condition would occur after language has been acquired in later life. And often this may be age-related and within the elderly life or in middle age through conditions such as Usher syndrome, for example. A deaf-blind person won't be typically usually deaf and totally blind, but both senses may be reduced enough to cause significant difficulties in everyday life. And often people who are deaf-blind will access the world and communicate through touch primarily. Issues can occur even if hearing loss and vision are mild, as the senses work together, and one would usually help compensate for the loss of the other. Now, I'd mentioned the See Hear strategy before, and the Scottish Government has developed a long-term strategy for anyone living with sensory loss in Scotland. And the strategy outlines 5 key recommendations for people living with a sensory loss. And they would be the seamless provision of assessment, care and supports to children and adults. That children and adults should expect the same access to education, employment, healthcare, social care and leisure as everyone else. And that people who have or develop a sensory loss will understand what this loss will mean for them. People who have or develop a sensory loss are able to access information and be supported to take the maximum possible control over living as independently as possible, while also getting direct assistance when needed. And appropriate communication is critical to this. And that children and young people with sensory impairment should expect appropriate and timely intervention in the early years and for as long as is required. And so from our analysis, we understand that over 1 million people in Scotland, over 1 million people in Scotland will live with some type of visual or hearing loss or both, and that's 1 in 5 of our population. But the vast majority of these people will be able to compensate for for this distance sense loss through either equipment or technology or societal relationships and support, or legislative measures such as assessment and registration. Research suggests that 50% of over 75-year-olds will have a dual sensory loss. We also know that a significant population growth in this elderly age group is due across the next 20 years, and research suggests a causal link between sensory loss and some types of dementia, for example. Also, within certain populations, such as congenital deafblindness and complex communication support needs, issues such as diagnostic overshadowing may exist, and this may create further barriers to timely intervention towards education and communication development. And so in considering this information, what does that mean for us in terms of how we construct approaches and support and that we can put in place when planning and developing services? So the Scottish Sensory Hub at the Alliance is based within the Health and Social Care Alliance, and this is an exciting new development for the sensory sector in Scotland. It draws experience from existing third sector organisations such as the Scottish Consortium on Visual Impairment and organisations such as Deaf Scotland. And the Scottish Sensory Hub acts as a platform for the voice of lived experience for anyone living in Scotland with sight loss, hearing loss, deafness or deafblindness. The Scottish Sensory Hub will act as a connecting bridge between the Scottish Government, the third sector and the individual, and will enshrine a human rights-based approach for all. And it really focuses on three key themes of communication, of information, and of mobility. And it looks to uphold the social model of disability, or the biopsychosocial model, throughout the sensory landscape in Scotland. And these three key themes of communication, information, and mobility will be central and relevant to anyone living with sensory loss, from a 2-year-old child with congenital deafblindness who may be learning communication and orientation skills alongside a communication partner, to a teenager with moderate sight loss who may be at college, to an elderly individual with profound hearing loss. The ability to communicate and connect with others, to receive information about oneself in an appropriate manner, and to navigate and travel around one's environment safely and with autonomy are fundamental human rights. We believe that we must travel from the medical towards the social model within the sensory landscape in Scotland, and that the disabling factor within an individual's life is not the medical condition per se, but rather society's inflexibility or reluctance towards change. And I believe there is an opportunity for further international collaboration and research within these areas. The human senses of sight and hearing are often the last to develop within the human fetus and are often the first to diminish within elderly life. It is likely that we will all develop and experience some degree of sensory loss within our lifetime. In areas such as elderly care and areas such as congenital deafblindness and complex communication support needs, there is an opportunity for the development of shared practice and joint learning to promote best practice for all. Thank you very much indeed for your time. Thank you, and I'm very happy to either take any questions or to look at the app later on as well. Thank you.
So thank you very much, Jonathan. And just because we were a lot of speakers in this session and we have added a new one, we are going to leave questions by the end, so we will be sure that we give the proper time to all the speakers today. And then later on, if we have a little bit more of time, we will be taking the questions. If not, as all of the questions are going to be remaining in the platform, all the the speakers can also answer online, okay? So thank you very much. And now we are gonna be giving the floor to Carolyn A. She is gonna be talking about the benefits of an Australian mother group specifically for women with substance use disorders.
Hello, I'm also a virtual presentation, and my presentation has been pre-recorded. Hello, my name's Carolyn A, and I'm presenting this.
This is always the same in online and
work that's looking at the benefits of a mother's group for women with substance use disorders in the Australian context on behalf of my colleagues who are listed here. And we're from the University of Sydney in Australia and the Sydney Local Health District Edith Collins Centre, which is also in Sydney, Australia. As is appropriate and custom in our country, I am talking to you from the land of the Gadigal people of the Eora Nation, so I would like to pay my respects to those people and acknowledge those people and pay my respects to their elders, past and present. So substance use in pregnancy and parenting services, or SUPS, which is a term I'll be using a lot throughout this presentation, can be quite a complex area. Pregnant women and mothers with substance use disorders face unique barriers to accessing care. There's a lot of fear around the social and legal issues and sanctions that they might experience. And as a result, many women avoid antenatal care and often come to care quite late in their pregnancy. And they often avoid other forms of treatment and engagement with healthcare and services as well. And this fear is also further exacerbated by stigma that's associated with substance use. And that's really compounded and magnified when we have women who are going to be mothers and also have histories and are using substances. Women with substance use disorders have a range of, there's a lot of disadvantage there for many of them. Many of them will have had a large number of adverse childhood experiences, so impacting on their own trajectories in life. And they may not have experienced, their childhoods are likely to have been such interrupted in the way that they may have been in care. So the usual exposure to parenting will be often not always there, so that their knowledge and experience of parenting is often very limited, and therefore they lack confidence in their own abilities. Mothers with mothers groups are a phenomenon that I'm sure many of you are familiar with. It's a worldwide phenomenon that's been found to be quite beneficial in terms of social support for mothers and by providing advice and reassurance for women. And participation has been shown to improve well-being. However, there's much less known about the concept of mothers groups in the context of substance use in pregnancy and parenting programs, or mothers groups specifically for women with substance use disorders. And so there's quite a literature that looks at different types of mothers groups in terms of a therapeutic environment and the way of providing treatment for women with substance use in pregnancy and parenting and women with substance use disorders. But this, I'm talking about something distinct from that, something that is actually just a mothers group where a group of mothers get together in an informal way, but is facilitated by a healthcare worker for them to discuss the issues of mothers of being a parent. And so we don't have a lot of, there's not a lot of data on this. We don't know much about how we can enable engagement in those kind of programs, how widespread such programs are, and also, so as such, there's a lot of uncertainty about the experience of these groups. And there's minimal literature exploring the healthcare providers' experience of operating these groups as well. So in Sydney Local Health District, we operate something called the Possum Play Group, which aims to support mothers and children with where the mothers have a substance use disorder, and to facilitate engagement in a range of multidisciplinary health and social services. So the group I'll explain briefly how the group operates, but it was established in the inner city area of Sydney, an area that has a high caseload of substance use in pregnancy and parenting clients, and it's open to pregnant women and those with young children in that local area who have a substance use disorder. So we operate weekly meetings, and it's a drop-in service. So there's no mandate, there's no you have to come. You simply turn up or you don't turn up. And most women, it operates out of the drug health clinic there. And the reason for that is most women, that's a place where women receive their drug and alcohol treatment, and they often know the staff and they're familiar with the environment. It's facilitated by nursing staff, but with a lot of with a multidisciplinary approach as well. There's paediatrics are involved, neonatal care, social work, and of course drug health. Different health-related topics are covered each week, and so there's a range of topics. So it's just information provision, and also we provide nutritious snacks for the children and for the mothers. So in this piece of research that I'm describing today, what we wanted to do was understand the perspectives and experience of mothers with substance use disorders, and also very much the healthcare workers, how they, what the role of the mothers group are, and what the barriers and facilitators might be. We actually had initially planned a much different piece of research when we set out a little while ago to do this work. It was going to be more like a process evaluation, including some qualitative interviews. All of that was unable due to COVID. So what we're presenting here is sort of this next best thing that we could do without being able to run and be part of the groups at that time. So as a result, we actually did a secondary analysis of 2 existing qualitative data sources where there were in-depth interviews already conducted with healthcare providers, people working with substance use in pregnancy services in that same area. It was a study that focused on developing a model of care for people with substance use in pregnancy and parenting issues, and 38 healthcare providers in the area were interviewed in depth for that. And also another study, which was qualitative interviews with healthcare professionals and clients who, again, were also very much exposed to this, to the mothers group. It's important to note that our methods were such in this case, because it was secondary analysis, we were not asking about the mothers group. It was merely that the mothers group, it became apparent that it came up. It essentially emerged as a theme in the data. And so we thought it would be a way that we could explore more about the group, given that we were unable to do what we wanted to do with COVID. So just to give you a quick background in terms of the methods, the participation was voluntary and informed consent was obtained. Human research ethics approvals were obtained. The interviews were conducted by people with a lot of expertise in qualitative interviewing and working with people with substance use disorders and healthcare workers, and was conducted by 3 of the people authors on this paper. They occurred in the participants' workplaces, research offices, or in clinic rooms. All the interviews were audio recorded. And for the women who took part in the interviews, they received a $30 shopping voucher, but the healthcare providers were not reimbursed. Analysis was reasonably standard thematic analysis for qualitative research, where we coded into a particular theme based on the subject matter, and then there were as a pattern emerged, nodes were formalized and subsequent interviews were coded into matching themes, and so forth. So what we found that there was explicit mention of the play group by 19 of the 38 healthcare staff in the first study, and by explicit mention, they mentioned it by name. That's not to say, or very clearly were referring to the group, and all but one discussed the group favourably as well, so very favourably. 2 of the 13 women in the other study had mentioned the group explicitly, and 4 of the 13 of the healthcare workers had mentioned it explicitly. But there was a lot, so outside of those direct mentions, there was a lot of the data was still rich in terms of understanding the need and role of the mothers group. So the themes that emerged were positive engagement with healthcare, ability to provide childcare in an informal setting, provision of education and parenting skills, and increased follow-up for treatments. And imbued throughout these themes was this theme of harm reduction. Harm reduction is a part of the Australian, it's one of the 3 pillars of the Australian National Drug Strategy, but it's not really been addressed directly in the context of substance use in pregnancy and parenting. It's been a little bit absent in that space, but what we found was that it was imbued throughout all of the interviews. So in terms of positive engagement with healthcare, the healthcare visits are often associated with having to explain and relive traumatic incidents in their lives, and therefore continuity of care is important, as explained by this particular neonatologist. I just think that families appreciate seeing the same person, and because they don't have to retell their drug history, and they don't have to explain what rehabs they've been through, or what they went to jail for, or why they lost their 2 last kids, or why they're at this particular women's facility with their baby now. The continuity builds relationships, and that's how we keep people in our system. So what you can see here is this real sense of trauma-informed care, that it provides that opportunity for trauma-informed care in a much more informal way. Further, there was the initial appeal of the playgroup is found through the social aspects. So you can see here that the healthcare, in the first quote, the healthcare provider, the group provides an avenue where these women feel safe and not judged, and they can turn up and talk about nutrition for their children. And then we can link them in with immunisation, just weighing their baby, making them feel safe. We also found that the women will attend for this reason, because of this safety, but that opportunity to build on healthcare as well and to get education. And you can see here that in this second quote, which was one of the women with substance use disorder, she was saying, just as in the course of the interview, which again was not explicitly about the mothers group, I have a drugs in pregnancy child group here, apparently. I popped in one day and we could go in and we could have a cup of tea. That is the mothers with substance use disorders, got to come in anyway, and then they could dose their methadone whilst they were still attending and their children were in the mothers group. They're like hanging out with each other once they've been dosed. Or as one of the other mothers also put it, you put the mothers and their children in a room with a baby health nurse, and those kids, they're going to be looked after. So this sense of, this is an okay, safe space in terms of healthcare, which is quite unusual in terms of the way women normally talk about healthcare provision when they've got substance use histories. Compared with regular healthcare appointments, the playgroup can directly benefit the children who attend, allowing an opportunity for children to interact with other children and play and learn together. And so one neonatologist pointed out that it's an opportunity, in the second quote, from the child's perspective, it's an opportunity where they have a stimulating environment, where they have the ability to learn, where they have the ability to just socialise with other children. And then, as the first quote points out, that provision of childcare is also really important. So the mothers can drop into the group and then attend to their healthcare. So as explained here, one thing about people with children, it's hard for them to engage meaningfully with these services. You're telling people to engage in these services, but they've got no childcare options that are available without paying a fortune. So there's that real benefit. The provision of education and parenting skills, it was also really important. I won't read through each one of these quotes, but there's an emphasis on the role of the mother, the women as a mother, rather than them as someone with a substance use disorder. It's all about the babies. It's all about them as mums, and having a lactation person there, and a social worker, and a Tracilian, so an early childhood nurse, and all the people that the nurse gets to come. It's got nothing to do with the fact that they use heroin. It's because they're a mum with a newborn, and I think that's great. And then, as you can see here, some of those educational opportunities can be really empowering for women, as explained by the martial arts defence classes, and that it's providing structure for the children as well. The group also allows for improved follow-up on treatment. It provides an environment for early intervention. That's why we've got some play groups, because they bring the babies back, as one healthcare provider explained. We get to see the babies again. The mothers are coming back to the hospital environment or the tertiary healthcare environment with the babies. So that's an opportunity to engage, and enables continuity of the newborn care as well, and reducing then some of those risks associated with newborn care and the children being lost to follow-up. So, for example, here, coming to that play group, so being linked into the supports, that if someone rocks up and says things like, I've really been edging to use, you can link them in with supports. Or if they say, I'm becoming homeless, or the domestic violence has started again, the social worker can contact the crisis intervention team and link them in with support. So overall, what we found was that the playgroup facilitated ongoing contact with the healthcare services in a trauma-informed way, whilst enhancing social connections for the women. Their motherhood is normalised and embraced in this context, and so they should not feel under surveillance or scrutiny by healthcare workers or societal expectations. It helps remove that or alleviate that concern that they're often experiencing. The need for reporting requirements is neutralised, allowing focus on the women caring for their children as an essential aspect to care and treatment. And the playgroup provided childcare and important social and developmental opportunities simultaneously. So it was twofold. It benefited the mothers in they were able to get that childcare when they needed it to attend to appointments, and the children got this important developmental opportunity as well. And providing educational training that should be in the form of parenting advice and other life skills can be empowering for women. So it actually is really empowering for the women. There are many limitations to this, and I've already described that we had planned to do this quite differently for COVID. Obviously, a secondary analysis of qualitative data is not ideal. But what I think is useful from this approach was that these were this was secondary analysis. We didn't prompt about the mothers group in any way. We weren't asking people about that, but that's what the healthcare providers and some of the women talked about. That's what they wanted to talk about. It became a key theme of other research. And we hope to do a process evaluation in the future. And we also want to really properly re-establish the group, which has really suffered as a result of COVID. And we're going to we want to speak more directly with the mothers about their how they feel about the group. But we've actually also got some plans in train at the moment to really expand the services. So we already had some dentistry connection, but we're really strengthening that, which is really, really important for this group of women, and it's very exciting. So in conclusion, the multifaceted aspect of the playgroup allows support at a time when the women are extremely vulnerable, and it provides support in an informal and social way. The safe, non-judgmental environment is highly beneficial to women with substance use disorders and effectively facilitates and encourages both treatment for their substance use and also engagement with healthcare services. We do know that more research is needed, and perhaps I'm coming in a bit late at the conclusion I mentioned early on that there was one negative comment. The negative comment only was that we don't really know whether it is beneficial. So there's a lot of hype around this mothers group, and people, the person was saying that lots of service providers want the mothers to attend this group, but we don't have solid data. So and that was the context of the negative comment, but that's something that we hope to address in the future to actually get harder outcomes for this very important integrated way we can integrate healthcare. So thank you very much. I would like to acknowledge the participants and also our wonderful nurse, Jill Martin, who got all this started and kept it running prior to COVID. Thank you.
And now we are gonna give the floor to Cecilia from Sydney too. So, Cecilia, it's online. Can you hear us?
Hello, I can hear you.
Yeah, perfect.
My presentation is also pre-recorded, and I would also like to acknowledge the Gadigal people of the Eora Nation, where I live and work, and pay my respect to elders past, present and emerging.
My name is Cecilia Corey, and I'm the Senior Social Worker at Sydney Dental Hospital in New South Wales, Australia. This public hospital is a part of Sydney Local Health District. This presentation will explore the benefits of having integrated care services and targeted interventions for vulnerable groups in a public dental setting. It will show this as an opportunity to provide much needed support, safety interventions, and holistic patient and family-centred care. It will also discuss the introduction of domestic violence routine screening, DVRS, within a dental hospital. The title of this presentation is a line from a text message from Susie, not her real name. She was referred to me by a dentist in our community oral health clinic for facial injuries suspicious of an assault. She presented with bruising around her eye. She had not disclosed domestic violence until she was asked directly. Months later, she sent me a message and said, "Imagine if I didn't meet you. I'd probably be in hospital or in a coffin." I will expand on her story later. In Australia, social workers like me are connected to most public health services and medical specialties. For example, orthopaedic wards, emergency departments, and community aged care settings. However, I am the first permanently employed social worker in a public dental service in Australia. From my investigations, I have found it is rare across the world to have social workers based in public dental. So why am I here? Demographically, a large proportion of our patient cohort experience disadvantage. This is because access to public dentistry in Australia is restricted to people on social security, with the exception of Aboriginal people, refugees, and asylum seekers. Our district has areas of extreme social and economic disadvantage, meaning a high number of people eligible for public dental. 40% of the entire state's boarding houses are in our district, and there is a high proportion of people living in public government housing. In the high-density public housing in the local suburb of Waterloo, 67% of the residents are 50 and over. 82% are on a government pension, making them meet the criteria to be a patient of the dental hospital. 11% need assistance with self-care. 48% are culturally diverse. There are higher rates of people accessing mental health services. Domestic assault rates are much higher than the average. Drug offences are higher, and 10% of the population identify as Aboriginal or Torres Strait Islander. This is relevant because the social determinants of Aboriginal health, including dispossession, interruption of culture, intergenerational trauma, education, employment, housing, environmental factors, and racism have impacted on health outcomes for Aboriginal people. Furthermore, our service is tertiary, meaning that vulnerable patients from all over New South Wales come to our hospital for complex and specialist services. So integrated care is really important to address our unique patient needs. Legal needs can be social determinants of health. The impact of where we live, poor or inadequate housing or homelessness, who we live with, domestic violence or child safety concerns, how we live, stress, anxiety, debt, or inadequate nutrition, all have an impact on health. In oral health, much of the advice is about maintaining good dental hygiene in order to prevent new disease and the restoration of effects of existing dental conditions. For some of our patients, following advice to focus on oral hygiene is unrealistic when patients don't even feel safe in their own homes, or in some cases don't even have homes. In 2019, Sydney Dental established a health justice partnership with Redfern Legal Centre. A health justice partnership is an early intervention program designed to identify and intervene in potential legal issues that frequently exist for patients in a healthcare setting. This is because legal issues can cause or compound health problems. New South Wales Law and Justice Foundation legal needs analysis found 20% of Australians experience 3 or more legal problems each year, many of which are associated with increased risk of physical and mental illness. Many seek no advice for these problems, but if they do, they are more likely to approach a non-lawyer, such as a health professional, than a lawyer. The partnership model takes advantage of this evidence, utilising health professionals to identify and refer clients with legal issues. Hospital staff are trained to recognise legal problems, as many patients and health professionals don't realise that lawyers can help with legal issues such as housing, fines, credit and debt, domestic violence, and so on. The partnership enables health workers and lawyers to work in tandem to improve the holistic health of individuals and alleviate the strain on the healthcare and legal systems. In 2021, Health Justice Partnership surveyed its clients. 67% reported reduced stress, 33% increased safety, 25% improved financial situation, and 50% improved housing situation as a result of obtaining legal advice. 83% indicated an improvement in stress levels, physical health, and a sense of control over their life. Having integrated services in Sydney Dental has allowed us to consider improving how we identify socially at-risk patients now that we have the resources and tools on site to support them. Sydney Dental Hospital's primary purpose is to improve the oral health care for communities who are vulnerable, marginalised, and experiencing the poorest health. The social work service uses a no wrong door approach, referring clients to health, government, and non-government community supports to address their psychosocial needs. The level of complexity and risk present in our patients has underpinned the decision to introduce domestic violence routine screening, known as DVRS. Evidence shows that positive screens are more prevalent in groups such as antenatal care, mental health, and drug health, making screening in these areas mandatory in New South Wales. It has not been done in a dental setting before. High-risk groups for domestic violence include Aboriginal and Torres Strait Islander women, women with disabilities, women experiencing financial hardship, people with problematic substance use, and women with mental illness, among others. High rates of people in these risk categories access public dental services. We are piloting the DVRS in paediatric dentistry, special care dentistry, where patients include people with a disability, people living in boarding houses, or people with complex mental health, and the community oral health clinic, where people go if they've experienced an injury or assault. DVRS will provide an opportunity for women to attend these clinics to access domestic violence support safely. In 2019, approximately 30% of the referrals to social work disclosed current or historical domestic violence. This slide shows statistics on facial injuries sustained in domestic violence assaults. Up to 94% of domestic violence victim survivors of physical assaults sustained facial injuries and 7.5 times more likely to have head, neck, and facial injuries compared to other trauma patients. In May 2018, the Australian Domestic and Family Violence Death Review Network found that when viewed as the escalation of a predictable pattern of behaviour, domestic and family violence deaths can be seen as largely preventable. They found that 76.2% of domestic violence abusers who had killed female victims had previously used physical violence against the female they killed. This shows that dental clinicians' ability to identify potential facial domestic violence assaults puts them in a very good position to offer potentially life-saving support. So, domestic violence is violent, abusive, or intimidating behaviour carried out by an adult against a partner or former partner to control or dominate that person. Domestic violence can cause fear, physical and psychological harm. It is most often violent, abusive, or intimidating behaviour by a man against a woman. In Susie's case, she is a 43-year-old woman who attended an appointment with bruising on her face. She initially said that it was from a fall. The treating dentist referred her to social work. She said a new boyfriend had punched her in the face and sexually assaulted her. She was very fearful of this man. Susie was not linked to any support services prior to coming to Sydney Dental. She said she had not been to a doctor or any health professional in over 2 years. She had a history of depression and had attempted suicide 4 years prior. She was homeless and living with a friend who had been violent to her in the past, and she was using intravenous methamphetamine daily. So, on meeting Susie, social work did initial safety planning. She was referred to her local community health clinic for sexual health checks, drug health and mental health support. They linked her back with a local GP who treated her depression and referred her to psychology. Susie attended a local police station to meet with the domestic violence liaison officer and obtained a restraining order to keep her safe from domestic violence. She was referred to district domestic violence counselling to gain understanding of cycles of power and abuse. Our district drug health services referred her to a local residential drug rehabilitation unit. She was also allocated her own public housing unit. Health Justice Partnership provided Susie with legal advice, support with her housing application, referral to New South Wales Victim Services that provided counselling, crisis moving assistance and monetary compensation to victim survivors of domestic violence. They were also able to assist her with debt she had incurred through financial abuse in the relationship. So from a single referral from the public dentist, Susie was able to access moving assistance, secure housing, furniture, domestic violence support, drug health services, mental health services, sexual health check, legal assistance, victims compensation, a restraining order and debt assistance. Hopefully, Susie's case shows the importance of identifying people that may be experiencing domestic violence. So why screen in public dentistry? The domestic violence rates in Australia are horrifically high. 1 in 4 Australian women have experienced physical or sexual violence by a current or former intimate partner since they were 15. On average, 1 woman a week is murdered by her current or former partner. There is clear evidence that women are unlikely to disclose their experience of domestic violence unless health worker directly asks them about it. This was the case for Susie, who acknowledged that if she wasn't asked about violence, she may never have told anybody. The research also suggests that women think it is appropriate for health professionals to ask them about domestic violence, whether they have been victimised or not. The public dental service is often accessed by patients alone, and follow-up appointments can be provided at a place perpetrators of domestic violence would not suspect women to be able to access support. The low identification of domestic violence across New South Wales health system warranted the introduction of routine screening for women in the previously mentioned key program areas where elevated vulnerability was identified. We believe the level of vulnerability in our patient cohort justifies routinely screening women for domestic violence. This slide shows the New South Wales Health Domestic Violence Screening Tool. Screening promotes awareness of the health impact of domestic violence. It asks questions about child safety. A discrete pamphlet is offered that includes information on domestic violence supports available. In introducing screening, we hope to identify more women like Susie and link them to potentially life-saving support. Screening can lead to earlier intervention, potentially less costly emergency department presentations or hospital admissions, less morbidity and mortality. In terms of maintaining oral and general health, women out of violent situations may have more space in their life to follow prevention advice of their doctors and less miss appointments, which equals better health outcomes. At Sydney Dental Hospital, the target clinical areas are working on protocols on how to use this screen safely in an oral health setting. This is done with women alone when it's safe to do so. You don't screen in front of partners or older children. If women are unsafe, they can be referred to support services and, of course, legal advice through our partnership. Some of these local Sydney and New South Wales supports are shown on this slide. If there are child safety issues that constitute serious risk, we would contact Child Protection Services and also link families to appropriate family support services. We can support women with the police to get restraining orders. If there are serious injuries that need attention or no time to create a safe plan, we would call on support of our local hospitals in the district. Lots of the time, women don't disclose domestic violence when screened, but all women are offered information and contact numbers. This is because we remember that 1 in 4 statistic, and maybe it's not for them, but their neighbour or their friend or their sister. Over 50 staff members have completed a 1-day course on domestic violence and routine screening. The pilot project was delayed due to COVID and should start in July this year. It's still a work in progress to adapt it to a dental and hospital environment, but we are committed to making it work because we think it's important. Thank you.
Thank you very much, Cecilia. And now, because we are getting a little bit out of time, we are going to be fast to give the floor to Clea Atkinson from Cardiff and Baylor University Health Board. So the floor is yours.
Hello, my name is Dr. Claire Atkinson. I'm a palliative care consultant and I work in the University Hospital of Wales in Cardiff, UK. And today I'm going to present a supportive care in advanced heart failure pathway, which is a new initiative started back in 2016, where we have been working in an integrated way as a co-speciality team, providing care for patients in the later stages of heart failure. So heart failure is a condition which has a very chaotic trajectory and often results in multiple hospitalizations, particularly in the last 6 months of a patient's life. Often there are many things that can be done earlier in the disease trajectory, and there are ever increasing options for prolonging the final deterioration. However, ultimately, all patients end up with a deterioration in the final phase of illness, as this is a life-limiting condition. So we were interested in trying to improve the symptomatology of patients and their quality of life in the last 1 to 2 years. We looked at this in Cardiff and Vale, together with our colleagues in cardiology. So what do patients like this want from healthcare? And we know from some of the literature that chronic disease patients actually want better pain and symptom control. They want to achieve a better sense of control when they're having this extremely difficult disease trajectory, and they want to actually relieve the burden on others and instead strengthen the relationships with those that they love and those who love them. And they also talk about avoidance of inappropriate prolongation of dying. So in this situation, patients are often more interested in rationalising of treatment options rather than rationing, but essentially quality of life is becoming increasingly more important as patients progress along their illness journey. And when we look at place of death, which is very important to patients, particularly in the palliative care arena, we're interested in that very much. As most people, according to the Voices study, around 81% of patients and people in general would prefer to be at home for the end of their life. But we know that advanced heart failure patients will often die in hospital in approximately the same proportion. And in the last 10 years or so, there's been an increasing evidence that palliative care input can really improve the quality of life and outcomes for these patients. We know that palliative care can improve symptom control, that we can help quality of life and well-being, both by symptom control but also by other holistic measures. We can help patients with self-efficacy and even help a heart failure patient go back up the functional classification of the NYHA. We can help patients with advanced care planning so that they can decide what they want to happen to them in the last 1 to 2 years of their lives. And we can lower readmission rates. And yet only around 6% of patients are ever referred to palliative care from this patient cohort. So if we look at advanced heart failure patients, there's certain things that we started to notice when we started to get involved in their care that were really important when we were deciding what kind of model we were going to try to improve the quality of life and the last 1 to 2 years of their disease journey. And we could see that they had really strong trust in their cardiology and heart failure teams. They've often been under these teams for quite a period of years, and there's often been instances where they've even had their life saved on a number of occasions by these teams. They often have a limited acceptance of the life-limiting nature of illness, primarily because the thrust has been at increasing survival, and cardiology are a very proactive team in that regard. So yes, the focus has been on extending survival rather than quality per se. And there's a dependency on acute services, which is reinforced by the repeated readmissions that these patients experience. which are often very frightening. They're often managed by a variety of different teams who don't know them, and they're just plugged into the acute service and get everything that a patient would routinely get, regardless of where they might personally be on their own disease trajectory. And it's very frightening during these periods of worsening condition. And they get lots of avoidable investigation and intervention. So these patients, when we meet them, tend to frequently be requesting that they don't want to come back into hospital, if at all possible. So we decided that we were going to try and redesign what we were providing to these patients, because the palliative care model that we had didn't seem to be helping with the engagement in the way that we needed with either the referring team or with the patients. So we decided instead to take a completely fresh view and start with an MDT. We knew we wanted to create a co-speciality model. So we started with a multidisciplinary team meeting on a monthly basis. And at that, we would discuss patients, both the new referrals who might be referred according to certain referral criteria, such as frequency of hospital admissions, NYHA status, having a very poor ejection fraction, or cardiac cachexia, and always being at maximum tolerated therapy. But also predominantly making sure that patients were being referred to us where there was agreement from the experts from the referring team that they were appropriate to start to come towards a more supportive, palliative model of care. We also at that MDT would discuss every patient that we were seeing to make sure that the cardiology and heart failure teams were feeling very much involved in the care of patients who they often had good relationships with, and also so that we could feel supported when we were starting to take over their care gradually as they progressed towards a later stage of their life, and also ultimately to the end of life. Part of what we would then do is we would see these patients in clinics, either in a parallel clinic where we had access to the cardiology and heart failure consultant and heart failure CNSs, but also we ran a joint clinic where they could see us together in the same clinic session. And we would also see these patients wherever suited them. So sometimes that would be in the clinic if they were able, but if patients started to become less well or were too unwell to attend clinics, then we might see them at home visit. We would also see them in other clinic settings if they were coming up for some other appointments, in order to reduce the amount of healthcare contacts that those patients were making, and for ease for them of navigating the system, and recognising the difficulty for them coming up to the healthcare setting repeatedly. So we then looked at our data, which we collected prior to the point of referral, and we looked at 1 year prior to the referral point, and we also then looked at the referral point to either the end of 2020 or to death if that came sooner. And we used that information to be able to compare the number of hospital admissions, either by episodes or days, before and after referral. Recognising that after referral, there were a number of interventions that we were making, including compassion-based rapport building, good symptom control, gradual advanced care planning, sometimes using subcutaneous diuretics in the community, or helping patients to access hospice when that was appropriate. We then used paired t-tests to demonstrate a relationship, whatever relationship there might be, by comparing pre and post referral. And the index data demonstrates that over a period of 5 years, we have gradually tended to a trend towards significance in terms of reducing hospital admissions. And that's both for heart failure related admissions and also all cause related admissions. On average, 14 days of admission for a heart failure related reason has been reached per patient, and that equates in the UK to about £10,000 cost saving per referral. And these patients on average are with us for about 0.78 of a year. And when we then looked at the patient experience data, because that was obviously extremely important when making an assessment of personal value for these patients, we found that a high proportion, over 80% of patients, would recommend this service to somebody else in the same position as them. Very importantly, they also feel that they're listened to and can discuss their thoughts and feelings, which is very much reflective of the emotional support that we provide. A high number also recognise the care that is being given as compassionate, and they feel that they can better understand their condition because we'd explain things to them. They also felt there's a benefit in their care coordination. And despite the fact that these patients often have extremely difficult symptoms to control, including breathlessness, fatigue, lethargy, etc., a high proportion felt that control of symptoms had improved, and indeed quite a significant number felt that symptoms had been resolved. We demonstrated there's definitely improvement in quality of life by involvement of this service, and many felt that we had helped to improve their sense of feeling a burden on the people that they loved. And a high number, up to over 65%, recognise the benefit of the joint speciality approach. And in terms of place of death, we've shown a significant reduction in the numbers dying in hospital compared to what would be usually expected. We've approximately halved the number dying in hospital, and in terms of those dying at home, we've managed to almost triple it. So the best approach for these patients, we feel, is this co-speciality integrated model of care. The synergistic benefit of two fields of expertise coming together to together tailor care for patients as individuals is highly effective. The tailoring of care, so as patients become less well, they need more individualized plans and to tailor really to their specific needs, and that's extremely effective. Cross-boundary care, so going to where the patients are. If a patient's not well enough to come up to clinic, then we need to go out to them. But also re-empowering patients so that they understand that we are a small team, we don't have huge resource, so we educate them about their condition and teach them to work with us so that they let us know if they need us, rather than having routine hospital appointments that they might or might not come to. We very much ask them to keep us informed of how they are, so that we can respond to that in a more flexible way, bringing them up to clinic when they really need it. And the flexible service model works extremely well. And very importantly, a compassionate approach. Patients who are frightened, who know that they're entering into a more limited phase of their life, and who often have been having repeated admissions that are very frightening, need to feel that they can trust the team who are looking after them. So we really, really focus on compassionate rapport building. So the benefits of an integrated model of care, the co-speciality team approach is highly effective. The ongoing mutual learning between two teams so that we learn from them, they learn from us. The better understanding of a fellow speciality's expertise. It's very difficult to explain to someone what palliative care provides. It's much more something that needs to be witnessed, either through seeing the impact on patients or by seeing us in action. And the enhanced collaboration that just makes for much more efficient care. And the development of interspeciality trust and respect, which helps to get over the referral barriers that have been there for a long time between specialities who are looking after chronic diseases, creating barriers to the referral to palliative care. and overall then an enhanced personal value for patients, so that basically they value the compassion, they would recommend this service to somebody else in the same position as them, but at the same time it's a lot cheaper. So in terms of getting this service commissioned, that's been a two-pronged benefit, and currently we are actually having funding to expand our service to other disease areas, including advanced renal disease, advanced liver disease, and pulmonary fibrosis patients in Cardiff and Vale. And the heart failure model is being spread across Wales to 4 other health boards. Thank you very much.
We're just going to give the floor to Carla Dix from Delta Wellbeing to talk about tech to support independent living.
Morning, my name is Carla Dix and I'm the Strategic Innovations Programme Lead for Delta Wellbeing. And today I'm going to be discussing our Delta Connect project. Just to put into a bit of context, really, probably facing the same challenges that many services across the UK are facing in terms of demographic changes, increased frailty with our older population, and some recruitment challenges into certain key roles within our health and social care services. This obviously then means that perhaps our traditional models of social care and health provision are perhaps not as effective and probably not able to be sustained into the future. Legislation in Wales prioritised prevention with a focus on asset-based assessment, and the development of regional partnership boards allowed for an emphasis on following a partnership approach to strategic delivery across our health and social care industries. Locally for us, about 5 years ago, Carmarthenshire Council had a care line service which had been in existence for, I say, over 30 years. Was deemed to be a loss-making service and heavily subsidised by the council, mostly due to the fact that within the UK it's a non-statutory provision with regards to assistive technology, but there were clear benefits of providing such a service. So a decision was made to create a local authority trading company, and Delta was formed, and that's actually opened up different doors to be able to work in a different way. Welsh Government created the Transformation Fund, setting aside over £100 million for the regional partnership boards to bid for. West Wales Care Partnership, our local RPB, having looked to our colleagues across in Spain, decided to submit a bid to provide a proactive tech programme to transform delivery of healthcare and support in West Wales. The RPB was successful in obtaining the largest single allocation for a project, with it being also seen as a national exemplar project. So connect objectives. By being proactive and preventative, the aim was to transform health and social care delivery by providing bespoke packages of care and wraparound services, as well as the tech, in order to improve wellbeing outcomes and maintaining clients' independence at home. This in turn would hopefully then see a reduction on demand within long-term delivery and health. This in turn would see a reduction in demand within long-term or acute health and social care settings. So specifically with regards to Connect, it provides a wraparound service provision. Bespoke tech and digital solutions are offered, and these are actually facilitated to the wider provision. Our community wellbeing officers support our clients, their carers and family by creating co-produced wellbeing plans, coaching to build resilience, and offering signposting and escalation dependent on need. Our proactive calls, whether that be weekly, monthly or quarterly, again depending on need, allow staff to be able to build positive relationships with our clients whilst enabling staff to pick up on possible triggers for crisis, thus ensuring that the right help can be provided at the right time. All our clients have access to a 24/7 response service. Our team are highly trained and are able to support with welfare response, falls management, and also to be able to support triage for ambulance teams. We are the only response service in Wales to actually be registered with our care inspectorate, which also allows our staff to be able to provide personal care when needed. We have very strong and close links with our third sector and community groups, which also then provides clients with community-based support when needed, helping them to remain well in the community. A key priority for us is to be able to become more joined up across health and social care. Connect and Delta's unique position has meant that we have worked closely with our partners to push these boundaries. I've just highlighted a couple of projects that we've worked on. We've been able to facilitate 5 local day centres to move to a virtual operation throughout COVID in order to be able to keep clients connected and also to offer some level of respite to family members and carers. Our telehealth project for monitoring chronic conditions has supported over 400 clients, and again we're seeing improved health outcomes and reductions in hospital admission for some of our clients. Delta's Blue Army, as we've called them, has been supporting hospital discharge and managing the flow within our local hospitals, with Delta staff being an integral part of MDTs, facilitating discharge by being based in wards, but also being able to help stop admission at the emergency departments. Our response service has also been supporting the Delta Blue Army by providing welfare support calls and bridging for care packages to enable early discharge, as well as supporting with a home from hospital service. I'm just going to play a brief video of some of our leaders giving their story.
Hello, I'm Jake Morgan, Deputy Chief Exec and Director of Communities for Carmarthenshire County Council. 4 years ago, we visited Barcelona with Tunstall to look at how they use telecare to proactively support older people in the city. We came back really impressed, but with some real challenges as to how the model would work in a Welsh health and social care system. 3 years later, we've launched and are delivering Delta Connect. It's a preventative model that stops people being sucked into statutory social care, enabling us to meet growing demand and a really challenging demographic in the county. Our model, delivered across West Wales to thousands of vulnerable people, gives a personalised wellbeing plan to around 1/3 of those who contact adult social care.
Our work with Delta has really leveraged the infrastructure which Delta Connect have in place already and maximised the benefit of this to provide a telehealth service to our health board in Hywel Dda. The service offers real value for money for us as an organisation. By layering tech-enabled care on the existing Delta platform, we have an opportunity to better help people lead healthy lives, to help prevent conditions from deteriorating, to detect any changes at a really early stage and to allow healthcare professionals to respond quickly. It's a way of making sure we target our work and our effort at those at greatest risk or at those who have greatest need without waiting for patients to present themselves.
A Healthier Wales emphasises the key role of regional partnership boards in driving the transformation and integration of health and care in Wales. Now, I'm confident that Wales is leading the way with a proactive and preventative approach to social and healthcare, using digital technology as a key part of this. The Connect project is an example of innovative approaches to using digital health and care as part of integrated care. That ongoing commitment of all partners to test new ground, to take risks, while remaining focused on those desired outcomes in improving people's well-being, has been key to the success so far and will need to continue to be so moving forward. I'm confident that this example shows that we really are moving forward in transforming health and social care in Wales, and how our partners are key to making that work and delivering the vision of a healthier Wales to make it a reality.
So we've been able to achieve significant outputs and outcomes throughout the project, and also through a global pandemic, which has provided its own set of challenges, as I'm sure many of you have experienced yourselves. We've been able to support over 4,500 clients across the region. So we've actually managed to get quite a volume through the system at scale, which was again one of the priorities. And that's allowed for more effective and efficient working practices to be developed whilst achieving economies of scale for our partners. Prevention has been the focus, and our proactive calls have ensured that people have felt supported and connected and have been provided with the right help at the right time. Our response team have been phenomenal, attending 6,125 call-outs in just over 2 years. And as we can see from the figures there, 41% of those were due to non-injurious falls. And when we consider that only 7% of all of those call-outs have actually been escalated to emergency services on site, we can clearly see the impact that our team has in preventing long lives and, unfortunately, from that, possible inevitable admission to hospital and all that follows. So it's been a huge success in terms of the response service. We've had strong client feedback, very positive overall. And through our outcome tool, we've shown that 82% of clients have an improved or maintained score, which is, again, quite an achievement. And just to clarify that, we have a few of our wonderful clients telling their stories.
82-year-old Rex had recently returned home after a long spell in hospital. His son would normally visit him daily to support him in his everyday life, but he was shielding during lockdown, so visits were not as easy. His mood was extremely low and he lost weight following hospital, which left him frail and vulnerable.
Oh, hello. Hi, it's Sian again from Delta Wellbeing. So how has it helped you having the phone calls every week?
All the people that phone me have been really nice, you know. They've made me feel at home. Longest time of the week was the weekend, waiting for Louise to phone me on a Monday morning.
Hi, my name is Gareth and I support people on the Connect programme with digital help. Digital inclusion was always a big part of the project, but this has become even more important in our response to the COVID pandemic. When the Community Wellbeing Officer works with someone, they give them a digital prescription which tailors apps and online content to help individual wellbeing goals. This can range from self-management apps to links to an online church. We are even using this technology to create a virtual day centre to replace our physical day centres that have been closed due to COVID.
I do karaoke every day with Tracy and talk to the boys in crosshands.
And I like doing everything on there, like joining in with people I do. And I do exercises twice a day on there. I go in the living room, I put the iPad on, and then I just move like this, and I move my arm like that, and then I just copy what other people do on it then. Yeah, and I enjoy it. Good exercises for you.
Connect have been wonderful. They came in and they set up the Wi-Fi for me. They gave me the tablet. They showed me how to use it. The best thing about this technology is that it allows me to live independently in my own home. And that's the best part.
In so many ways, my independence has been taken away from me, which has made me completely housebound. Therefore, my button is all I've got with the outside world, really. Well, my pendant, it is my lifeline. It gives me confidence. I know that when I'm in trouble, and I have been in trouble on a number of occasions from falling, that I've only got to press it and the response is immediately.
So Connect has certainly achieved some wonderful results, and I, for one, am very proud to have been part of our journey so far. So we've had clients with improved outcomes. We've supported earlier discharge and helping improve that hospital flow. Our professional teams have a higher level of confidence that those clients that they are dealing with are safe and are looked after well at home. And I suppose all of the above then drives that reduction in our ongoing pressures that our services are facing to hopefully ensure a sustainable model for the future. By being proactive and preventative, it allows for appropriate interventions before needing an escalation, possibly to statutory services or into acute settings, whilst coaching and mentoring our clients to be able to cope and manage better, builds their resilience in the community. So what next for us? It really is about understanding the art of the possible. We'll continue to maximise our agility with our highly skilled workforce, be at the cutting edge of innovation through our tech offer, and ensure that the client is at the centre of all we do and continue to learn from our experiences. Thanks for listening.
So thank you all of you for being until the end. We have been out of time. And the last thing, just I would like also to invite you for Wednesday workshop. It's called Beyond Cancerless, Building Up Strategies to Guarantee the Scalability and Transferability of the Health Navigator model to real-life setting across Europe. It's about cancer prevention and homelessness population, and I think it's really aligned with the objective of this workshop and things that we have been touching in different sessions. Okay, thank you very much.
Jij mogen.